We'll get started in about 2 minutes. We'll just wait until 9:05 to make sure that everybody shows up. Good morning, everybody. Welcome to the first of our SCCR Science series. The EKG classes have always been a very popular, little louder? Is this better? Okay, great. Our EKG classes have always been very popular. In fact, one of the first science series that SCCR started out with was the Anatomy and Physiology of the Heart and Basic EKG Interpretation. Since then, in the last few months, we have heard from many of you about how you'd want to learn more about how to conduct and interpret EKGs. And so today it's my great pleasure to welcome you to this class. Let me introduce you to the speakers. Kiera Larsen received her training from the Duke University Nursing Program and has worked for many years as a pediatric cardiac ICU nurse. She has also been heavily involved in clinical research. She now brings her expertise to SCCR. She's our education program manager and has been critical in setting up a lot of the education and training initiatives and classes that many of you have already attended. And today she's going to be teaching us about conducting EKGs. Rhonda Larson began her career at Duke University and worked as a clinical PA in the cardiology division, administrator for the Duke Cardiology Associates Group, and manager for the Congestive Heart Failure Research Group. She then directed cardiology site research coordination, where she managed 22 study coordinators for over 50 to 60 ongoing clinical trials. In 2002, she was appointed director of site-based research for the Duke Clinical Research Institute, and in 2005 was appointed to a faculty position as Associate Vice Chair for Clinical Research for the Department of Medicine at Duke University. She's currently a clinical assistant professor and the Associate Program Director for the newly approved Masters of Science in PA Studies at Stanford. So please join me in welcoming our two speakers today.
Okay, thanks for coming. We have a pretty good turnout today, so I'm really excited that you guys are all here. Just a couple of announcements. Can't hear? Really? Okay. that better? Just talking louder, projecting more? Or the microphone's not on?
They're on.
I don't know where to turn this up. Okay. So just a couple of announcements. So we're doing these science series for all clinical research staff. We don't have this room every month, but look out for some flyers. Next month is going to be a lecture on pain and the current research that's going on within the pain division. And then in April, we have a speaker who's currently an internal medicine resident, and he's going to be talking about common medical terminology and acronyms for all of you. And then in June, we have an outside speaker, an external speaker coming from UCSF. She's a PharmD, Kathy Orko, and she was here back last year, about a year ago, and she spoke to us about pharmacokinetics and pharmacodynamics in clinical research. So she is coming again to talk about some advanced topics in that arena, as well as some ideas around precision health, which goes very nicely with our dean's message. Is that better? It might be because I'm a little bit sick. I can also hold it up closer, so it's better. Okay. All right, so I'm going to be talking today about conducting ECGs, and I will use the terms ECG and EKG interchangeably. Many of you know they are the same thing, but EKG is used because ECG sounds much like EEG, so I'll use them interchangeably. They mean the same thing. So here's our agenda for today. I'm going to talk about the ECG definition, the purpose of the ECG, why physicians and other providers will order an ECG, or if it's part of your research protocol, the necessary supplies that you're going to need to conduct the ECG. We'll talk about proper skin preparation for the leads, and then we'll get to the proper lead placement with my mannequin up here. And then Rhonda will come and talk to us about the interpretation. So what is an ECG? I'm sure many of you are aware of this definition, but wanted to review. So we're going to be talking about a 12-lead ECG. There are 3-lead ECGs as well as 5-lead, but we're going to be talking about a 12-lead, and usually the 3 and 5-lead are used for transporting patients or telemetry units, but a 12-lead ECG is more accurate, and we will be showing you where to place these leads. So a 12-lead ECG, electrocardiogram, is a medical test that is recorded using leads attached to the body. The ECG captures the electrical activity of the heart and transfers that activity to graphed paper. Results are then analyzed by medical professionals. So why perform an ECG? There's a number of reasons. Could be part of your research protocol, but many times it's to record a baseline reading of the heart activity. And this could be part of research. It could be before a patient starts a medication that could perhaps alter the electrical activity of the heart, or a procedure. It's also used to identify changes or problems in the conduction system of the heart. Obviously can be used to diagnose issues. If a patient comes in with chest palpitations or has had an episode of syncope, many providers will go to the ECG first to get an underlying understanding of what the conduction system of the heart looks like. ECGs are very accurate. They're very safe. It's a quick test to do, and it's fairly inexpensive. So you will see them in many research protocols these days, as well as an easy test to do, and it doesn't hurt the patient. So here are supplies that we're going to need for the ECG. You will need an exam table. You should not be doing or conducting an ECG in a chair. It's not accurate and not the right way to do it. And actually, before we get into this, how many people in the room have already been conducting ECGs with their patients or research participants? Okay. And how many of you know that you may be doing this in the future? Okay, awesome. So for supplies, so we need our table, and your table should be at a 20-degree angle or less in order to conduct the ECG. They should not be sitting upright. It helps with proper landmark to put the ECG leads on appropriately. We'll need some alcohol swabs to prep the skin, which I'll get into next. Our electrodes, our cables for the ECG machine, graph paper, which should be in your ECG machine, but you always want to make sure that's full and ready to go, your ECG machine, a gown or a blanket for the patient, and then either scissors or hair trimmer or a razor for people who are have a little more hair, and you're going to have to remove those in order for the ECG leads to stick on appropriately. So next thing we want to do is communicate effectively and appropriately with the patient or research participant. So you want to make sure that you explain what the ECG procedure is and the amount of time that it will take. Confirm that it's okay for you to go ahead and start wiping their skin down, that they confirm and consent to this procedure. You don't just want to come in there and start, unbuttoning their shirt and telling them, okay, we're going to hurry up and get this done. And so you just want to make sure that that's okay for them to do, for you to do with them. Make sure that you wash your hands. And then you're going to want to enter the patient demographic information into the ECG machine. These, this is an example of one down here. They're all a little bit different. Some of them are bigger and you can't carry them. They're all made by different companies, so the information and how it comes across the screen may be a little bit different, but it's pretty basic. It's patient name, patient birth date. Sometimes it asks for weight or height. So just make sure that you become familiar with the ECG machine that you're going to be using. And then you're going to want to just remind the patient to relax, to breathe normally, and to remain still. And during the time that you're putting on leads, it's fine that they're talking and moving around. That doesn't matter. But as soon as you actually push print, you're going to want to remind the patient to please remain still. Please, we're just going to be silent for a few seconds. This isn't going to take long. But in order for the machine to work properly and for the electrical activity recorded properly on the graph paper, just remain still and we'll be done in a few seconds. So talking about proper skin preparation. So you are going to want to ask the patient to remove his or her shirt, socks, and shoes. For female patients, it should really be a bare chest. So you are going to want to ask them to remove everything that's on their chest, and that's why you want to provide them with either a blanket or a patient gown for modesty, but also, as we know, these rooms can be kind of cool, so you want to make sure that they have something to cover up with. And then we're going to prep the skin of each lead area where the electrodes are going to be placed. So you're going to do that with alcohol, just regular alcohol pads. Sometimes either the sponsor will request a different way to put the leads on. Sometimes they come with little like sandpaper. It's really fine sandpaper. It doesn't hurt the patient, but it will kind of remove that first layer of skin, and then you're going to alcohol prep that and put the lead on. But usually it's just alcohol. And then, like I said, body hair and motion are the biggest reasons for artifact with an ECG. So if there is body hair, you're going to have to remove that, either, like I said, with a razor, a hair mustache trimmer, or scissors. Just remove that with scissors. And then lotions and moisturizers and sweat are also reasons for poor adhesion with the electrode. So make sure, obviously, use that alcohol and wait for it to dry completely before placing that electrode on there. And then you're going to want to place each lead firmly onto the skin, and we're going to walk through this, but don't just put it on there and expect it to adhere. You're going to really need to press down around the whole ECG lead. And then just as a reminder, never place leads over ports or pacemakers or open skin or incisions. You want to make sure the skin is intact and healthy, and just don't put anything over anything that looks like it would be affected by that adhesive. Okay, so let's get into the proper lead placement. We're going to talk about our limbs first. There are 4 limb leads, 2 on the arms and 2 on the legs. And I like to do this first just because it's easier than the chest leads, and you get those 4 leads out of the way, and then you can focus on the 6 precordial leads. So I like to do my 2 arm leads first. They're labeled with these cables as RA and LA for left arm and right arm. And you're going to want to place the lead on the inside of the wrist, below the elbow, and then on soft tissue. Don't place it on the wrist bone or any other bony prominence. And usually this is a nice area because there's less hair as well. So when you remove the leads, it doesn't hurt as bad, or you don't have to remove that hair. hear me still? Okay, okay. So right here, you're going to do right arm and left arm, and then go ahead. I would advise just to go ahead and attach your cables to the leads right away, and it helps with kind of separating, because this can be a little bit overwhelming looking at it, how many cables there are. So go ahead and do your arm leads first, and then you'll go ahead and do the leg leads. And same label, right leg and left leg, RL and LL. And same place, similar to the wrist. You're going to want to do that on the inside of the ankle. Again, below the knee. And then on soft tissue, don't put it on the ankle bone. So I'll just show you on me. So like right here, right on this area. And if you can find, it doesn't matter if it's on the pulse, but that's a nice landmark. If you find the pulse, posterior tibial pulse, then you can just place the lead there. But again, as a reminder, make sure you prep all these areas with the alcohol and wait about 5 to 10 seconds to let that alcohol completely dry before placing the electrode on, or that it won't adhere to the skin. And then, like I said, go ahead and just clip your cables on right away. It makes it easier for the chest leads, and they're out of your way, and it's a little bit more organized. Okay, so we're going to do a little bit of practice on ourselves. We have a couple mannequins. So at the end of the class, there's 2 of these guys, and if there's time, then I welcome you guys to come down and actually practice on these guys. They do have some pretty good landmarks. You can feel some of their ribs, so it's a nice way to practice. But for purposes right now, we're going to kind of practice on ourselves. So the first ECG lead we're going to place is V1, but the first thing we have to do is locate the proper landmark, and that's going to be your 4th intercostal space. And then intercostal is the area between your ribs, the cartilage, so it's a soft area. So the first thing you want to do is just take your right hand and kind of sit back in your chair if you can. Don't sit upright, it makes it a little bit tougher, but sit back in your chair, take your right hand and find your clavicle. This is your collarbone. And then you're wanting to take 1 to 2 fingers and place it right underneath your clavicle. And that should be a soft kind of area, and it depends on your anatomy, but it's either 1 to 2 finger widths between the clavicle and the rib cage. So next, you're going to want to feel for the next bony prominence. This is the start of your ribs. This next bony bone right about here is the first rib. And then you just want to move down, and again, it's about a finger width between ribs. So you want to move down and stick to the sternum. Don't go out into this area because you won't be able to feel it as well. You can really feel your ribs closer to your sternum and your breastbone in the middle. So you want to go right in the middle of your chest here. And you're just going to work progressively down until you feel for the 4th rib. And right underneath, and it's right kind of in the middle of your chest, depending on your anatomy. But right underneath that 4th rib is your 4th intercostal space. And that's where you're going to place the first lead. I went through all that. So again, I just want to remind anatomical position. So when you're talking about the patient, you're talking about the patient's positioning. So if you're facing the patient, it's always the patient's right side or the patient's left side. So it can be a little bit confusing when you're talking to someone about what side you're going on, if it's your left and their right. So just make sure when I say you're going to be placing the lead on the right side of the patient, it's obviously the patient's right side. Okay, so chest leads can be a little bit confusing, but I think we've broken it down here, and I think it'll be pretty easy to go through. So we've just located V1, 4th intercostal space at the right sternal border. So right about here, and I have my little mannequin here, so right about this area here. The next lead we're going to do is V2, and V2 is on the same exact place on the left side. But I encourage you, don't just go right across and go, oh, V2 must just go right here. You want to make sure that you find the proper landmarks on the left side of the patient's body as well. So what you want to do is on the left side with your left hand, do the same kind of thing. Find your clavicle and move your way down through the left sternal border here, all the way down to the 4th intercostal space on the left side. And it should match up, but there have been cases where it doesn't, so just make sure that the landmarks are proper. So we have V1 and V2. And then the next thing we're going to do is get a little tricky, and we're going to skip over V3 and go directly to V4. So for the V4 lead on the left side, and what the leads look like is they make this kind of semicircle around the heart. The heart is on the left side of the body. This is where most of our leads are going to go. So here's so we have V1, V2. We're going to skip V3 for a second and go directly to V4. So with V4, you're going to find the clavicle again on your left side, and you're going to go down the middle of the chest. And with women, it's under the breast tissue. So you don't want to place it on the breast tissue, you want to place it underneath. So it's kind of right in line with the nipple, and V4 goes right here. So mid-clavicular line, and that's going to be your 5th intercostal space. So right below where V2 is. So this is V4. So the next lead we're going to do is V3, and V3 goes right in a diagonal with V2 and V4. There's no need to find landmarks with V3. You just want to place it in a diagonal fashion between those. All right, instead of going to V5, we're going to go to V6. So this one's a little bit, not too tricky. It's not bad, but it's actually on the lateral side of your patient. So you want to ask the patient or participant, when you're putting this lead on, to lift up their arm, because it helps with proper landmark. So you're going to find the mid-axillary line, so right kind of in the middle of the armpit, and then trace all the way down the lateral aspect of the patient here, and then V6 is going to go right horizontally in line with your other leads, V3 and V4, or V4. Yeah, V4. So V4 is here, and then your V6 lead is going to be lateral aspect, so right in line, right on my mannequin here. And then finally, your V5 is similar to your V3 lead. You're going to go right in between V4 and V5. Or, sorry, V4 and V6, so right here. So these all should be in line right here. Does that make sense? Want to review it again or practice later? Review it again? Yes? No? Okay, we'll review it one more time. Okay. We have some time, so. Okay, so V1, we're locating our 4th intercostal space, so with your right hand, leaning back, locate the clavicle. Use 1 to 2 fingers underneath your clavicle to locate rib 1, and move down right by your sternum, don't come out here, and then all the way down, feeling rib 2, intercostal space 2, 3, all the way down to 4, rib 4, intercostal space, right along the right sternal border. V2, right across, but left hand, left clavicle, mid-clavicular line, right in the middle of the clavicle, moving down, finding your ribs, and then getting down to V4 and your intercostal space right around here. So that's where V2 is. Skipping V3 and going to V4, mid-clavicular line, right in line with the middle of your chest, and again, 5th intercostal space, so right underneath V2 in terms of ribs. 5th intercostal space is V4. V3 is the diagonal, so right in between V2 and V4. Place that electrode there. What did you say? Don't do that. Oh, yeah, no, don't do that. Okay. And then skipping over V5 and going to V6, lateral aspect of the patient, mid-axillary line, ask them to hold their arm up, find kind of their armpit area and move down. Same horizontal plane. It should be the 5th intercostal space, but on the lateral aspect of the patient, so right here. And then last electrode, V5, right in between V4 and V6. So no landmarks, just know that you got these 2 right, and it's just placed here. Okay, so at the end, I think we'll have enough time to practice with these guys. We have some more leads. We have 2 mannequins, and I think this is I don't think everybody will end up staying, so we'll have some time. And if there are more people who want more practice, I'm happy to work with you to find a time that works with you guys, and I'm happy to come over and either be your mannequin, or we can use this guy, or whatever you prefer. Any questions about lead placement and skin preparation or anything like that? Okay. Wrap up with the ECGs with our patients. So once you have your ECG and you think it looks okay, and these machines, they'll label things. They will tell you if something's wrong, or if you look at the waveform of each of the leads and something doesn't look right, or it will tell you, but it's not going to say, no, this isn't right. So we just want to make sure by looking at the waveforms that everything looks okay, and that's what we're going to discuss in the next part of this, to really be able to identify, does this look okay? Are my leads in the right place? Is everything attached appropriately? So you want to make sure that you review your ECG and then have your PI review it as well. It's really frustrating to do an ECG, have someone look at it and say, can you repeat it, and you've taken everything off. So I recommend just asking the patient, you know, just hang out for a few minutes. I'm going to go and talk to my PI. If your PI is around, review that ECG, make sure it looks okay before asking the patient or removing all those ECG leads, because you're going to have to do the whole process all over again. So again, just cover the patient up, tell them that you'll be back in a few minutes, and to just hang out for a few minutes so they can review the ECG. And then I like to ask the patient to remove their own leads. I think it's probably less painful, but you can ask them and say, do you prefer me to do it, or you can do it, but I think it's nicer. I worked with pediatrics, so I could never ask them to remove their own. I always had to do it myself. So it's just a little bit painful if they do it themselves. Okay, any questions before we move on to interpretation? No, okay.
Good morning. Can you hear me okay? I'll talk louder. In case you haven't noticed, our names are the same and the whole Duke thing. This is my daughter. So the only thing I would ask is on evaluations, could you please evaluate me higher? I don't care how bad or how good my lecture is. If she gets higher than me, it's going to be very painful at my home. So please consider that.
You came with jokes. I wasn't prepared.
So this is EKG 101. So this is just to give you an overview and interpretation. We'll practice, we'll go through it. We'll review some at the end. I'm sure we'll have time. We can do placement, we can get in small groups, whatever you think works best for you. But this is a tough subject to teach in the time that if you get into really the vectors and the conduction, it can be a little overwhelming. So as Kiera pointed out, it is known as EKG or ECG. This was invented by Wilhelm Einthoven. He was a Dutch doctor, and he won the Nobel Prize for this in 1924. But because of the European spelling, that's where the EKG first came in, but you'll also see it with the American electrocardiogram. So as she said, that's synonymous. This is your typical EKG, your 12-lead EKG. This is not normal EKG, but this is where Kiera pointed out your limb leads are here. All right, well, we'll show you more in the end. But this is the graph paper. It is a little blurry too. We'll show you the graph paper because it'll be important for you to look at your graph paper and see how these waves are lined up. But just what I want, this is just a 12 lead. So your chest leads are V1, 2, 3, 4, 5, 6 that Kiera has showed you nicely on this mannequin. And then these are your limb leads on the left. This down here, Kiera, oh. This down here is a rhythm strip. So I know it's blurry, but again, these are one beat, heartbeat, heartbeat. And this is capturing on the chest leads and the limb leads. But this number 2 is usually your rhythm strip is number 2 down here. And this is the rhythm that you're taking through the whole thing. These are snapshots, but this is the rhythm strip through the whole thing. And again, we'll review this in more detail. But what you need to understand is when you're placing these limb leads, you're really getting a picture from all different angles of the heart, where the electrical conduction is coming up from the legs, from the arms. But these are different camera views of how the electrical vectors and conduction of the heart and what this ECG is comprised of. This is a little bit better picture. If you look in lead 2, which I just explained, this is the rhythm strip that goes all the way across. So this is a snapshot of lead 2 with 2 beats. This is the same heartbeat, and at the same time, but this is the rhythm strip all the way across. Does that make sense? Yes? Okay. Lead lead 2, rhythm strip all the way across. I won't use the pointer if it's not helping, but so that's the lead that is the best placement and usually the one that is capturing the heartbeat through the entire ECG of what you're recording.
Sorry, I still don't understand the difference. First and 2 is capturing.
This is capturing just 2 heartbeats. This is just a snapshot of that. This heartbeat right here where my finger is the same heartbeat as over here in V1.
Oh, I see.
This is the same heartbeat, 1, 2, 1, 2, but it's just capturing it from different angles of the picture of the camera that I was showing you.
Okay.
But this is the heartbeat all the way across. Yes? Geez. This one? Yep. So we have lead 2, which is this lead all the way through the entire ECG, and these are the beats, beats 1 through 14 that you're recording. Got it? Yes. But I'd be remiss if we didn't just review the conduction of the heart and what you're actually capturing. So remember, there's 4 chambers. You have the left and right atrium and the left and right ventricle. So unoxygenated blood is coming in the right atrium, through the tricuspid valve, out through the pulmonary valve, gets your oxygen in the lungs, and brings it back through the pulmonary veins. The pulmonary veins are the only veins in your body. The pulmonary veins are the only veins in the body that carry oxygenated blood. Every other vein carries deoxygenated blood. Comes through here, and this is how your circulatory system works. Comes through, pumps through, this is a better picture, but deoxygenated, goes to the lungs, oxygenated, out to the body. And it's this squeezing mechanism that we're going to talk about. Did you take my water? I put it up here. Thank you. And it's this conduction and squeezing that we're going to be talking about on the electrical conduction. So let's get some definitions. Myocytes are the actual heart muscle cells. They're negatively charged at rest. And it's this negative and positive polarization that happens that causes the electrical stimulus and contraction to occur. So just so you have the definitions, depolarization is a wave of electrical energy that progresses through the heart, changing negatively charged myocytes, negatively charged cells, to positively charged. When that occurs, contraction occurs. And again, this is what we're going to learn is a normal EKG has a P wave, atrial depolarization, which conducts through the heart to get your ventricular contraction, then rest. And the whole cycle occurs again. We'll go through these independently, each one independently. So where does the electrical conduction system start? It gets from the sinoatrial node, which sits in the right atrium. That sends electrical conduction through this system, which we're going to go through. So the sinoatrial node, the SA node, is where it originates. That's where depolarization, it spreads through both the atria, and this results in the P wave, the one I just showed you. That's the start of the electrical conduction cycle, P wave, atrial depolarization. As it travels through, it then goes to the AV node. And the AV node is the only conducting pathway between the atria and the ventricles. And depolarization slows down at that AV node, producing a brief pause, which is what you see here. Here it's conducting before it goes into the QRS complex. So all of this is happening in milliseconds of time. The bundle of His is right here. You can see that was named after Wilhelm His, surprise. And he studied the electrical conduction system of the heart, and so this bundle was named after him. And then this travels down the bundle of His out through these Purkinje fibers. And that's where the heart gets its reading on the electrical conduction to squeeze. It's all the purple. So the AV node, so it starts up there with the green, the SA comes to the AV node and then travels down the bundle of His. And so I know my pointer's not good, but right here, that's the left when you see left bundle branch blocks. And then this, if you have problems here, this would be a right bundle branch block. Yes, and we'll have a couple, you know, again, this is EKG 101, so yeah, you will. And EKG machines do pick this up and will often see it, but that's where you're having abnormal conduction, is down that pathway. Does that describe? Yes? Bundle of His and the Purkinje fibers. This is a great name. It's a great name. Purkinje is a fun word. So then you have depolarization of the ventricular myocardium, and that's what you're known as a QRS, the big ventricular contraction. Oftentimes, you may not see, the Q is this downward, and many EKGs will not have that Q, and we'll go into reasons why. There's many reasons why. Many times that can predict a previous myocardial infarct, but this is your QRS complex, and the Q wave is the first downward wave of the QRS complex, which is followed by this upward R. The upward R is where you often see in the chest leads when you've got bundle branch blocks. So the chest leads is where you're looking for bundle branch blocks. Getting back to your question. So that QRS, the Q may not always be there, and that's still normal. Then you have this horizontal segment after the QRS, and it's the ST segment. And normal level of ST on your EKG, and that's why these grids are so important on the EKG paper, this line needs to be equal with this baseline line. And when they're off, there's many reasons why that can be off, but in a normal EKG, those lines, this line here and this line here, need to be equal on the paper. And then the T wave represents the final rapid phase of repolarization before rest, and then the cycle will happen all over again. Yes, Lindsay?
Is the peak segment and the or do you mean equal on plane as well as length?
No, not length. Plane, plane only. Plane only.
Okay.
Not length. Do you have questions back there? Are you okay? Good?
What equal is plane versus length?
I think that's a little, yeah. Yeah, I may have some examples at the end, but what happens when you're having a heart attack is this ST segment here will be elevated.
Oh.
So, and EKGs tell you so many things, so that's why we'll get into some abnormalities at the end, but we're looking at normal EKGs right now, so no heart disease, no problems. This line will be on the same grid of this line. And you'll see they're 0.02 millimeters on the paper, so that they're that close that you'll want to be able to follow that. So the QT interval is ventricular systole, so when the contraction is occurring, begins with a QRS, begins with this cycle here, and ends until the end of the T wave. So this is your ventricular contraction. So this is the graph paper, and again, we have samples that we'll go over as a class at the end, but this is how the graph paper is, and each one of these is 0.04 seconds. So a whole grid, and they're boxed, they're highlighted like this. There's 5 boxes within this one larger highlighted box, and this larger box is 0.2 seconds. So the grid already counts this stuff out for you, and we'll go through what normal and abnormal intervals are. And again, your EKG machines will do a lot of this for you. So when you see a normal EKG, these chest leads that she placed here are what you're seeing here on V1 through V6. And remember, the heart is sitting like this. So it's taking electrical conduction from various angles. So you're not going to see the same wave. It wouldn't be helpful if you got the same wave. This is showing you the normal chest lead and ventricular contraction across these chest leads. And you can see up here in V1, it's a small R wave. Then as you get closer to the center of the heart and conduction, the R wave gets bigger, and then bigger, and then bigger and bigger, and starts to fall off because you're going stronger, stronger impulse and less impulse. Does that make sense? So the one thing I can tell you on EKG, you're not going to learn how to read a total EKG in here, but we'll give you some things to think about and ask yourself. But the most important thing you can do on an EKG is do the exact same thing every time. Don't get to a point where you look at an EKG and you go, oh, that's abnormal. What's abnormal about it? If you're not systematic about an EKG, you're going to miss something, because you can look at that rhythm strip on the bottom and get a pretty good idea, which we'll go over how to look at, is it regular? Is it irregular? Do they have extra beats? Is something missing? Does something look funny? You have to do it the same way every time or you're going to miss something. So the first thing you do is rate, which we'll review how to do that. You're going to look then at the rhythm. We'll talk a little bit about axis. Axis can be very confusing, but the axis is how the heart sits. What is the axis on a circle? Is the heart sitting normally? Is the heart tipped to the left, which you'll get when you have like a lot of hypertrophy in the heart and the muscle gets wide and thickens, so it shifts the heart? Do you have congenital heart defect that maybe you have transposition of your vessels and it shifts the heart to the right? So the axis is how it sits in the chest, but it can be difficult to explain, and I'll do my best. We'll go over intervals, we'll talk a little bit about blocks, and then we'll show you some EKG findings that you'll see with a hypertrophied heart, and then what happens with infarction. Can I get me some more water? Oh. So, you know, normal sinus rhythm, normal rate for a heart is between 60 and 100. So if it's less than 60, you've got bradycardia. You don't know if it's sinus bradycardia, you don't know, but it's slow. You've got bradycardia. And if it's greater than 100, you've got tachycardia. And the foci throughout the heart is capable of pacing when an SA node is dysfunctional. So sometimes, remember how you saw the SA node and it had that little circle and then it went to the AV node? Sometimes when the SA node's not working great, it has other ways to conduct, conduct and get the electrical stimulus there. So we'll talk a little bit about that. But here again is your graph paper. Can you see the bold line, bold line, bold line? And you've got the 5 boxes in between. So your R to R wave is 1 heartbeat. So this is your atria depolarizing, your ventricle, it's the end of contraction, it's resting. Your atria, so it's 1 cycle. So to count your rhythm, you want to find the R wave that's the closest to this bold line. This is a perfect example, but this R wave is on the bold line. And then how you count the cycle from there is you look at the rhythm strip, the one on the dark line, And then you count from one box to one box, and you'll remember this. You'll just put this in your head. 300, 150, 100, 75. This heart rate is probably right about 76. But just put that in your brain. This never changes. When I look at an EKG, the first thing I do is 300, 150, 175, 60, 50. I mean, I just look. Memorize those numbers. They'll never change. Does that make sense? You see how that's counted? So this is 300, 150, 100, 75. So it's a little bit faster. It's probably a 76, 77. Doesn't matter. It's still normal if you're. Each one of these boxes that I showed you is 0.2. So each one of these is 0.04 milliseconds. So that's a heart rate of 76 beats per minute. 300 beats per minute. If you had another one that was right here, the R wave was right here, your heart rate would be 300. If your R wave was here, your heart rate would be 150. If your R wave's here, it's 100, and if your R wave's there, it's 75. So you'll just look at that rhythm strip and you'll go 300, 150, 100, 75. And what you're going to worry about is if it's over 100 and less than 60. Are we okay here? I see some confusion. We'll go over. So the next, so that's your rate, right? That's the first thing I said to do. You have to look at your rate. The next thing you want to look at is your rhythm. Is the rhythm regular or irregular? And if you look here, you'll get calipers. If you don't have calipers, you can take a piece of paper and mark either a P or a Q or S. You can go with a P, and you mark it to the next P, and then you mark it to the next P. But if you have calipers, you're walking this out, and you're walking it out. Is that regular? This is a regular heartbeat. It is a regular heartbeat. You have a P. It's equal. You don't see, and I'll show you another one that's abnormal, but you'll see one that's here and then here and then here and here and here. And then, so you'll see irregularity. But when you look at this, nothing strikes you. You don't see two quick beats here and then everything else is. This is a normal, regular rhythm. The other thing you want to look at on the rhythm, because you're trying to figure out if it's a normal sinus rhythm or you're always looking for a P wave. Remember, we went through the normal morphology is P, Q, R, S, T. Is there a P wave for every QRS? P wave, every QRS. P wave, every QRS. This is a rhythm strip. So this is the rhythm of the entire time this EKG was on this patient's chest. And if you want to do a rhythm, what is it? Here's one right on a bold line, 300, 150, 100, 75, 60. Probably going to be somewhere about 66. So that is a normal ECG with your rhythm. I'm going to skip that right now. So your intervals, these are the intervals that we're going to start to measure so you can look at and understand what are normal intervals and abnormal intervals. The PR interval, that's the atria conducting down to the ventricle. This is your PR interval from here until the QRS starts. A normal P interval is 0.2 seconds. So again, on an EKG, you're going to look at a P interval. It's very easy on EKGs if you have a P for every QRS, and you look at the P, and you can measure it right at the beginning of that bold grid line. If it's within a box, within that 0.2 box, the 5 boxes, that's normal. If you're measuring it and it's outside a full box, it's abnormal. So a normal PR interval is 0.2 seconds, which is a full box. QRS, a normal QRS is less than 120 or 0.12, which is the 3 small boxes within a box. They're 0.04 per box. 3 of those is 0.12. So remember, a normal PR interval, 0.2, a normal QRS, 0.12. The QT interval is the time taken for the ventricles to complete that cardiac cycle and for everything to start over. So you can see the QT interval is here. It varies when your heart rate changes, and it can vary with a lot of drugs. This is one of the most important things for those who are studying pharmacologic drugs, new drugs. They will be asking for EKGs a lot, because if your QT interval is prolonged due to there's other reasons within your own body, but pharmacologically, if you're taking a drug and it increases that QT interval, it increases your risk for sudden death. And the FDA didn't do this for a long time, and I don't know, many of you are too young for this. Do you remember Seldane, which was an antihistamine, and people took it for their allergies, and it was very popular. Everyone wanted this. Well, they weren't measuring this when this new drug came on the market, and there was a lot of people that were dying. When they started to look at it, Seldane increased your QT interval, and they had to take that off the market. So on new drugs, you will see that they're going to ask for EKGs a lot, because they want to know about that QT interval, because then post-marketing, when people start having these issues. So that's something that's very common. So let's talk about abnormalities. What did we say? The norm, oh, it's on here, I can't even quiz you. The normal PR interval is 0.2. So this is the exact thing I was talking about with a box. This is the 0.2. But see, the P starts outside this box and it ends outside this box. So already you know your PR interval is abnormal. Your PR interval is prolonged. And there's a lot of reasons that we can go into, but the PR interval is prolonged here. So just find one that's near that box and measure it and see if your PR is within a full box or outside of a full box.
Rhonda, I have a question. So if it doesn't line up nicely within the box at the beginning of the dark line, do we just count like 5?
That's where your calipers come in.
I see. Okay.
So you take your calipers and you measure from the start of the PR to before the QRS, and that's what your calipers. Then you can take your calipers and put it on the grid. But usually on a rhythm strip, you're going to be able to get some idea on that, because you have a number of boxes at the bottom to follow. So these are, yes? That's this. You knew my next slide. Thank you. I'll pay you after the class. There's a lot of variations in why PR intervals can be abnormal. I urge you to go to YouTube and watch Diagnosis Winky Bock. That's another great name. That's why I went into cardiology. We have all these great names, Purkinje fibers. And go to Winky Bock, because a med school class did Justin Timberlake's song, I'm Bringing Sexy Back. And they did it, Diagnosis Winky Bock, and they kind of go through the whole thing of, we should have done that. I bet we would have gotten really good evaluations on dancing around and talking about why you get, so there's different, and if you have an abnormal PR interval, you have a first degree AV block. How many have heard AV block, first degree AV blocks? Okay. But there's variations in first degree and second degree AV blocks. So when your PR interval is abnormal, again, this laser isn't going to work, but I'll try and point as best I can. So do you see in this one how your PR looks pretty short, right? It's only a few boxes. Then you come to this next one, I can tell you that one's already greater than a full box. And then you come to this one, uh-oh, look how long that is. Gets short, long, longer. Here it is. Where's the QRS? It just drops it. So this is what's called Winky Bock. It's first Mobitz type 1. It's a second degree AV block, but you have Mobitz type 1, Mobitz type 2, and I'll show you these differences. But so that's why I say be consistent every time. Because if you just get an EKG and you look at it real quick and you go, oh, there's P waves for every QRS, and you're not consistent looking, you're gonna miss it. You're gonna miss something, and this is not something you wanna miss. So in the second degree AV block with Mobitz type 2, you can see that you have this PR interval, P, no QRS, no QRS. The PR intervals in a Mobitz type 2 measure the same. They're the same every time, they just drop a QRS. But you don't see them lengthening, and drop. That's the difference between type 1 and type 2. Yes?
These sorts of abnormalities, would patients be symptomatic in any way, or is this
It's a great question.
pop up?
Yes, they can be symptomatic, and many times they are, but they can have it and not know it. But yeah, when they get, because they can get dizziness or lightheadedness because they have that moment where the ventricle isn't squeezing blood. And it depends, what is their heart rate when this is going on? Sometimes they can live with this without any problems, but others, you may need pacemakers, you may need other intervention. But yes, that's a great question. You can be symptomatic with this. And then the third degree AV block is a really, really bad one. This is life-threatening. You really want to get a pacemaker in these people. And this is, you're just not conducting anywhere. Look how long this is. And these patients are usually very symptomatic. PR intervals are long or dropped or short, and they're just not conducting in there. So third degree AV block is a scary one.
Would that be, would they be bradycardic at that point, or?
They usually are. You will see this a lot of times with infarcts, especially on the right side, if you have a right-sided heart attack, because that's where the SA and the AV node are. So you'll see complete heart block. If people are having an inferior infarct, which is on the right side of the heart, you'll see a complete heart, not all the time, but many times that will happen because they're having a heart attack on that. So the myocytes are dying, the cells are dying, so it's not conducting. So the first degree AV block is just a prolonged PR interval. Usually it is consistent over that, but that's why, again, you want to measure. But usually it's consistent, that you have a prolonged PR interval throughout, and that's type 1. I'm sorry, first degree. Second degree is when you have these variations of type 1, type 2, and complete. But watch the Winky Bock video. It's kind of funny, and it'll make you remember what to think about, it's cute, and it'll help you remember what the patients are experiencing. So this is when many of you, if you have patients with pacemakers, this is what an EKG looks like with a pacemaker, because the pacemaker is sending the electrical conduction system. You're not generating yourself. And so the electrical conduction system is going to look different than in a normal. And so these spikes, these are spikes to cause, and this is probably an atrial ventricular pacemaker, but this is what's sending the conduction to this node. And so when you do these, I don't want to get into it, but if you have someone with a pacemaker, you'll put a magnet on their chest, and the magnet turns off the pacemaker. and you can see what's going on underneath the pacemaker on their normal heart. And then you take the magnet off, and you can see with the pacemaker spikes again, if it's 100% capturing, is it only capturing when it needs to? And this is what the electrophysiologists do. This is, they come in for their pacemaker checks, but now they can do it by phone, and it's awesome. And I just want to touch base on a couple things, and we can go over some EKGs together. But many times you, and this is what I study mostly in heart failure patients, if patients have hypertrophy, which is, you'll see this often in patients who have high blood pressure. So your heart's a muscle. If your blood pressure is high and your heart is constantly pumping into this high pressured system, it's like lifting weights every day. So your muscle starts to hypertrophy. You build those muscles. And what happens is the muscle thickens in here, but look what happens to the ventricular space. It gets encroached upon, right? So patients will start to feel, this is very similar symptoms to what patients will feel like with heart failure. Their symptoms can be very similar, but heart failure, the heart's not squeezing, so you don't get enough blood out. The heart is weak. But in hypertrophy, it's banging away. It's just a really active muscle, but it's not allowing a lot of blood to get in the ventricle. But what happens, you can imagine that's a high, this is a CrossFit heart, and the spikes, because it's really banging away, you're going to see really tall R waves in your chest leads. And when you see really tall R waves, and you have to measure them because they have to, depending on which ones you add, they have to be 25 millimeters high, 25 together with, depending, again, 25 to 35 millimeters high. And if they meet that criteria, then by definition on an EKG, they have a hypertrophied heart. So look for that a lot in patients that have long-standing high blood pressure. And then this is what I was talking about when a patient comes in and they've got chest pain, they're short of breath, maybe radiating to their arm or neck, but they feel like they have this elephant sitting on their chest. Women typically have different symptoms than men. The typical for men is the heaviness. Women many times can come in with very, very different symptoms. But so you've got a clot or some blockage that's causing these myocytes to die. And so the conduction system isn't changing. But when you see ST, so P is over here, Q, R, S, what did I say about the ST? Needs to be on that same plane. This is not on that same plane. And many times the higher this is, the worse it can be. And the way you can look at that on an ST segment and determine where the heart attack is occurring is because if you're having a heart attack in the front of your heart, you're going to see different ST segment elevation versus if you're having a heart attack in the back of your heart, you're going to see different ST segment depression or elevation. So depending on where the heart attack is, it can help you say when a patient comes in with ST segment elevation, and I'm not going to teach you about that today and all these different leads, it's going to help the doctors know when they go in to do a cath where they look at first or last. So we'll just review a couple of abnormalities on rhythm strips that we can talk about real quick. And then Kiera can pass out some and we can go over them together. We can get in small groups, whatever you think would be most helpful. So these are some common rhythms and abnormalities that you'll see. So up here, you have a PQRS, 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 PQRS. But see how these look like they're pretty even, right? There to there, there to there, there to there. Does that look the same? But you still have a PQRS, and then it picks back up. So that's a premature atrial contraction. Patients may or may not be symptomatic with this. If you take, I bet many of us have these, if you take your heart, has nothing to do with the plane. It has to do with this beat right here coming sooner.
That graph, the S is not on the same plane as the P, right?
I think it's on the same plane. But the point,
Point out the actual atrial.
yeah, so this is the atrial beat, and it's just because it's a shortened that you have a QR, well, you don't even have a Q here, but you have an R and S. The point of this rhythm is that from here to here,
I understand that.
Yeah.
But I was just bringing an extra point here.
yeah, I think it's just because it's occurring very fast still, but it's not an abnormal morphology. This one, you see, can you even pick out a P wave in here? Pick out a bunch of them, and none of them are the same. So when you have atrial fibrillation, the atria is fibrillating like a can of worms. So it's not being a nice impulse, 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 impulse. It's going like this. So the ventricle picks up one here and picks up one there. And in atrial fibrillation, you will be able to help diagnose that by an irregular heart rate. So you can see that you have a strip, that is not the same as that, then you have this, and it's just the ventricle is only reading a few beats every now and then, and because it's not picking them up regularly, you have an irregular heart rate. And depending on this rate is about 300, 150, 175, a little more than 60. Atrial fibrillation can be a very fast heart rate, and it can be a slower one. This one is a slower one. So patients, when they're in a rapid AFib, are going to be very symptomatic. Mm-hmm. Right. You don't, because it's an irregular rhythm. But what you can say is this isn't rapid. This isn't a 300 or 150. This is a fairly slow, yeah, they have a fast one here, but it's a fairly slow one. You don't know their underlying unless you have a previous EKG to know when they're not in AFib. And then atrial flutter, you can see pretty distinct P wave, and the P wave morphology tends to look the same. This is a 3 to 1. So a flutter, this is 3 to 1, 3 to 1. And a flutter is usually a little bit slower, but usually an a flutter with a 3 to 1, you usually have a heart rate around 150, 100. But you can see a 2 to 1 a flutter. But do you see the difference that this is kind of wormy-like? There's no consistency. But this one you have a pretty good consistency, and then on QRS. So that's the difference between a flutter and a fib. And then the last ones I have to show you is a rhythm strip, and this is a premature ventricular beat. You can see that it's a ventricular beat because it's a widened QRS, and it's just an extra beat that comes in there. And many people will have PVCs, they're called PVCs, premature ventricular contractions. It's normal to have 1, 2, many of us can have it, but if you have a lot of them, people can be very symptomatic. Sometimes people that have a lot of PVCs that drink coffee in the morning and get a really caffeine urge can have a lot of PVCs, and you can be symptomatic, like lightheaded, not feeling that great. It's just because you're not getting a good contraction of cardiac output coming every time. These are ones, if you ever see this one or this one, call 911. These are deadly rhythms. You really should, if you're in any kind of situation in a clinic where a patient can be talking to you in this, they can be, and not feeling good. They're rarely talking to you in this, and they'll be passed out. But this is a deadly rhythm that patients go into. So I put these up there because they're important for you to trust. And you can see that they're wide complex. And when it's a wide complex, it's ventricular. So this is a wide complex. And when you get ventricular arrhythmias, those can be deadly. AFib and A-flutter that I just showed you, not deadly, usually not deadly. But this is a deadly one. So you'll really want to get your fibrillation kit together on that one. And then we can pass out some EKGs. I'm happy to go through them with you for what we have. You can review them if you want to ask questions yourself, whatever you think would be most beneficial to just look at. I think it'd be good for us to look at I think the first one has just some examples and your cheat sheet on your rhythms and your intervals. And then we have some EKGs to look at and we can go through. But it's good for you to just sit in here and practice looking at the EKG, doing the same thing every time. Rate, rhythm. You can.
I have to share, so if you have a friend who's I can send you.
Yeah, I think she will do that. I think so. I don't know but I think that's fine. I think it's fine. Yeah, you're welcome. Was that helpful?
Yeah.
It's a lot to take in.
It is a lot.
And you guys, I will tell you that just this class is not going to teach you EKGs. This takes dozens and dozens and dozens of readings before you will start to feel. I've been in cardiology 25 years, and I still see EKGs that stump me. They're not easy, but it's important that you understand and get the same thing every time and how you're looking at them and knowing what to look for when you're in trouble.
Really quickly, if you guys are leaving, there's sign-in sheets. It would be awesome if you would just initial, ask your name, and let me know. So please sign in before you guys leave.
Kiera, do you share the presentations?
Yeah, I can send them to you. Sure. That'd be great. Yeah, sign in, and I'll make sure you send it to the right people. What are you gonna, or how are you gonna do this?
I don't have any to look at, but I'm happy to. Do you want to do these together? Do you want to do them yourself and we come around? What's together? I'm going to need to see one.
Here, I'll get you one.
So this first one is just a reference sheet, but let's look.
No, the first two didn't, but if you go to the other one.